I think what did I push that? There we go. Look at that. I'm just going to give a little bit of an overview, not to bore anybody, but just kind of get everybody on the same page, and then talk about what our role is individually. And then I'm going to spend a little bit of time on the vaccine that's rolling out and answer a lot of questions about that, because that's brand new information for a lot of folks. And I don't know that I can achieve that fourth objective, but I think we all are on the same page there. So why am I the one that's giving this talk? First off, I'm a sucker, I guess. So early on in the pandemic, everyone was scrambling to try to address it at the workplace, and it's no different with us. We had to implement policies, and we had to talk about how we were going to manage patients and staffing, and so it was new for everybody. You guys went through it on your end, we went through it on ours, and so I kind of was one of the lead persons in our clinic to start doing that. So I had to essentially take a master's class in COVID over this past year. It pretty much eat, drink, and sleep coronavirus until I'm nauseated. So I have a lot of information in my head. So hopefully I can consolidate that and share it. But I've also seen how the testing has changed since the beginning. You know, since I can't tell you how many deep nasal tests I've performed on people. But thankfully, we're at a point where we can do a test that's less invasive, either an anterior part of the nares or a pharyngeal test, things that don't really require as much pain and discomfort, and it's not as fearful. And then in August, I spent a couple weeks in the NBA bubble, and their policies that they put out were informed by some of the world's experts at CDC and Johns Hopkins and infectious disease specialists. And so just sifting through that amount of material, some of it has stuck. And so that's why I'm the one giving this talk, and not one of my partners. So they haven't really let it stick, I guess. And they're smart, I think. That's why I'm the one having to do it. Okay, so background. Coronavirus is a type of viruses. Just like influenza virus is got several types. Anybody ever test for influenza A or B or have an athlete with one of those? And so there's different types of those viruses. Coronavirus is no different. The one that we're dealing with now is different in the sense that it's the very first presentation of this virus, and so everybody's kind of new to it, naive to it, so to speak. But that last bullet point on the slide is the one I want you to remember, is the way viruses work. It's different than bacteria. The way viruses work is they get inside a cell, and they use that cell to make a bunch of copies of itself. And then eventually that overwhelms the cell, and the cell either bursts or dies or whatever. But they essentially replicate themselves many times over, and then they go on to the next cell. And so how that works, so that many people can get infected from one. The transmission is mainly airborne, mainly by respiratory droplets or aerosols, things that are in the air, which is why we're all wearing that sort of thing. So anything that requires deep breathing, more respiratory droplets, coughing and sneezing can actually propel them at farther distances, which is why the whole 6 feet thing comes into play. 6 feet is not a magic number. It's just a safer number than 3 feet. This coronavirus is that people can be contagious before you even know it. That's one of the big sticklers, is that most of the coronaviruses we deal with regularly, like like the common cold, most of those viruses will give you symptoms, and then you know you're contagious. You know, you get aches, you get fever, you get stuffy head, cough, things like that. Well, this coronavirus, SARS-CoV-2, does that as well, but it gets into the body and can replicate itself so quickly before any symptoms are manifested, and then that person's contagious and doesn't even know it. That's one of the scariest things about this virus. Another thing about this virus that's consistent with other viruses is that it can change. It just like every year we have to get a flu shot because the flu changed a little bit. This virus is already doing that. It did it before it got over here from China. It changed a little bit, and it changed when it got to Europe, and it changed when it got to South America. And so there's these minute changes, and every change that it undergoes is a change to make itself be able to live longer, right? To withstand the defenses of our immune systems. And so it finds a trick, and it implements itself. And that's why we've never been able to get rid of the common cold, is because the virus does that. Well, the common cold is not really that deadly. It's annoying, it's not deadly. And so this coronavirus has a little bit more lethality to it. But we think eventually, once everybody's had some immune response to this thing, that lethality will drop significantly. I'm going to pause there, because that's a lot of information, and see if anybody has a question about any of that right there. Yes, sir.
Already occurred, we see the diminishing numbers of deaths reported. Is that due to the mutation? Is that due to treatments? Is that due to we have a larger test sample? Or is that a combination of all three?
Okay, so that's a good one. So the question is the numbers recently, the diminishing, is that due to a change in the virus? Is that due to treatments? Is that due to other measures? And I would say it's definitely not due to a change in the virus, but with one exception. But what the virus doesn't want to do is it doesn't want to kill someone right away, because then it can't replicate, right? And it's not like it's that smart, but it's not going to be able to replicate very often if that happens, and so it doesn't make those changes. So I don't think that the drop in percentages is due to changing virus. I think it's due to better treatments. I think it's due to a little bit more vigilance and maybe some measures like we're all doing right now. Can we get infected in this room? Absolutely. But the dose of virus that we might get is much less if we're wearing a mask. And so the infection is going to be less invasive. Does that make sense on that? So the response of the host, of the person that gets infected, has a lot to do with how much virus they initially got. And so if you get exposed and you had some sort of barrier and didn't get as much virus to expose you, you may end up with a lesser infection, and that's a better thing. So that would cause less percentage of deaths. Good question. Anybody else? All right, moving on. Here's symptoms. They're listed everywhere. I'm not going to bore you with those. Recent studies show that most people with symptoms, the more prominent symptoms are fever and cough, okay? And that most people that have a milder course are starting to show a higher number of loss of taste and smell, temporarily. Occasionally those things get prolonged, but those are symptoms that we didn't know about early on. The loss of taste and smell early on, we didn't know that was a big deal, and it started to show up, I think, and then more and more people developed it. So that may have been due to some of the change in the virus, but it acts like any other cold might act, in that fever, cough, congestion, headache, runny nose, sneezing, those types of symptoms. And so if someone has those symptoms, those checklists are there for a reason. You should think coronavirus. I cannot tell you, even my own staff at the clinic, people have said, well, I just usual hours. And excuse me, because this is cedar season, and those of you that suffer from it can verify we've had some tough days this week. But to assume that it's cedar is probably not wise at this point, because we're in the middle of a pandemic that even in our community, I'd like to just sign that it's more than that. Okay? And they can start to manifest symptoms, but it may not show up at 2 days, may show up at 5 days, may show up at 7 days, may show up at 14 days. So the reason some of the CDC guidelines started out with a 14-day quarantine period was because it can take that long to show up. Well, statistically, over 60% of folks will develop symptoms by day 5. By day 11, it's upwards 87, 88%. So the farther you go in it. So by day 14, if someone has exposure and hasn't manifested, it's unlikely that they're going to have it. But you can't say within 2 days of exposure that if you're not symptomatic, you're good to go. And how that comes into play is if you have an exposure and you get tested on day 2 or 3 and it's negative, that can be a false sense of security. And day 5, you might start manifesting. So I'm not saying you don't get tested if you're worried about it. I'm saying don't let that one give you the confidence that you're not going to develop. You still got to maintain safe practices and be alert for symptoms. Now that's important. Any questions about that? Yes, sir. Yes, ma'am. Sorry.
For that scenario where the patient does exhibit symptoms throughout that 14-day period when they're exposed, do you still recommend they see a physician for clearance, or say they've never been symptoms, they're negative? How many procedures?
I'm sorry. I'm going to ask you to repeat that one more time.
Was it, they're exposed, day 2, day 3, no symptoms, day 11, day 14, still no symptoms, so presumably they were negative because they're exposed, right? So in our case, here in this room, do those cases still need to be seen by physicians to be cleared to play, for return to play?
Good question. All right, so I'll repeat it for the group. So in the scenario I gave, somebody that gets exposed, if they go through the 14 days and they don't develop the infection, do they need a clearance note from a physician? My answer would be no, because they never developed symptoms. And even if they had an asymptomatic infection, the chances that they're spreading it at that point is really close to 0.
Do you recommend a test at the 14 days?
No.
Just 14 days?
No. I mean, not right now in our community daily. Ideally, we'd have a lot more availability of tests so that anyone that's asymptomatic can get a test. In fact, I'd love to see at-home tests on Amazon for $5, right? That would be wonderful. That would be something that I'm surprised that hadn't happened already. But the problem is there's a lot of logistics to it, and so the price of the at-home test is $100. And so right now, when so many tests are needed for symptomatic people, it's not advisable for people that are asymptomatic to just go get a bunch of tests for 14 days and then, you know what I mean? No. More than 50% of new cases come from asymptomatic people spreading it. More than half. And I would say there's a large portion of the symptomatic spreaders that are denying that they actually have symptoms. Because I've done enough of this year to, I'm sure you're familiar with the term contact tracing. I've done enough contact tracing to talk to patients about when did you get exposed or how long have you had symptoms, to know that they go, well, No, I've got zero symptoms. Okay, so you don't have a fever? No fever. Like 99.8, but no fever. Okay. You don't have a cough? Absolutely not. Just the usual cough. Maybe it's a little worse, but just the usual one. Okay. Body aches. Well, I've been working out. Okay. Fatigue. Yeah, but I just thought it was because I wasn't sleeping. Why aren't you sleeping? Well, I'm coughing. I'm like, you see where this is going? It's human nature. Human nature is, I don't want to think the worst about myself. I don't want to think that I'm infected. A. B. I don't have time. C. And this is a biggie. If I don't work, I don't get paid. So I can't be infected. Just bottom line. And so, while more than 50% are asymptomatic, there's a large group of people that are just symptomatic and just denying. And I don't know how to change that. That's just the way it is. Fortunately, a little more than 80% of people that get this are going to recover like it was a cold, right? Like it was maybe the flu, maybe a little bit worse than a common cold, maybe a little bit, but not bad, right? Most people are going to be able to kind of ride it out, take a little Dayquil, NyQuil, cough syrup, whatever, and recover and just come back to work in the appropriate amount of time. So, why is this such a big deal? Well, it's a big deal for a couple of reasons, from just logistically, a couple of reasons. One is what I mentioned earlier, which is you get this high level of virus in your body once you get infected. You don't even know it. Okay, so that leads to unknowingly being a vector of transmission. Well, somebody we would call a typhoid Mary, back in the days of typhoid, who exposed a bunch of people. They didn't know they had typhoid. So, same thing here is that again, I've emphasized this again, but you can spread it. We don't have any defenses for this from an immune standpoint yet. We don't have any defenses for this, and so if someone gets a lot of virus in their body and they don't have kind of the immune system that's been there, done that, seen it before, ready and primed for a repeat look at a virus, then it's got to start from scratch to try to fight it off. And sometimes it's fine, and sometimes it's not. And it's not for a lot of people who have already had an immune system that's a little bit slower to respond, whether that's through chronic infection, or they have chronic lung disease, or they're on medications that suppress the immune system. There's a number of reasons for that, but that's why there's a big outcry. I have heard the argument that people say it's not really worse than the flu, and the flu kills people every year, and we don't get all hot and bothered about it. Well, true, but we are actively trying to reduce that, right? Our bodies have seen forms of the influenza virus that can fight to some degree, and there's a vaccine offered every year. And it's not the greatest vaccine, but it does help some. So it's not that it's much more lethal, it's just that it's all at once. And if you've paid attention to the news in Kansas or in Los Angeles right now, the all at once is what's hurting them. They just don't have the infrastructure, nobody does, to handle the amount of infections all at one time. It's just too much. Where does it occur, right, in the body? What does it infect? Well, it infects the upper airway first, because it goes through the nose and the mouth and the trachea, and then it makes its way down into the lungs, and that's where initially it really gets going, right? You get the cough, you get the symptoms, the trouble with the exchange of oxygen and breathing, so it feels tight. A lot of people say it just felt like it was a lot more effort to breathe. And then the airway gets really almost spasmodic. It's almost like you take a breath to stretch the airway and it coughs again. It shuts down like a bronchitis would. I'm sure you guys are familiar. And so the cough can be just disabling. People can get diarrhea from this. It's really hard to ascertain the degree of involvement of diarrhea in this, but it's on the list. And so if somebody has congestion, headache, chills, muscle aches, and diarrhea, but doesn't have fever or cough, I still would say, hey, hold on, that might be this virus. It might be another virus, but it might be this one. It can affect the nervous system. We talked about the loss of sense of smell and taste. And taste has a lot to do with our taste. So I think it's part and parcel of both there. And then you heard about the cardiac system already and the myocarditis that can develop. And then vascular system can show increased levels of clotting. And people can get their little vessels that go to the ends of their body, like the toes, can get clotted and they can not deliver blood flow to them. And then their toes, in this case, COVID toes, their toes can get black, purple, because they're starting to die off because they don't get blood flow. And then the kidneys. You can get acute renal failure and acute kidney illness from the onslaught of the virus. So this map has been something that many of you, or maybe all of you, have seen before in the last 12 months. This is a map that I look at almost every day just to kind of see where we are. It's a little depressing in the sense that the U.S. is leading the way in infections. And there's a reason for that. I mean, we have a large population, 300 million or more folks. We have areas that are really highly dense. But the overwhelming reason is because there's just been such a fight to be unified on how are we going to approach it. There's just differing opinions and arguments, and so we haven't been unified. Some countries that have similar, not as much population, but similar density population have done a great job of being able to control numbers of infections and therefore numbers of deaths. But currently, there's 87 million cases and 1.9, perhaps 1.9 million deaths since the beginning. And those are numbers that we know of. There are probably some that aren't out there. And so let's go back to the argument of how does that compare with the flu? Well, in any one flu season, about 1 billion people get infected with the flu. And somewhere between 500,000 and 600,000 people may die from influenza every year. That's in a 6-month typically period, October to April. So double that, and you can see that this virus has a little bit more lethality to it than the influenza virus. And again, I think that's all because it's just brand new. I think with time, we've got some good treatments like we mentioned. I think that's going to drop even more. So how do we prevent it? Wouldn't that be nice if we could just not get it? I think everybody knows, because everybody's wearing a mask, that's part of the deal. Wash your hands, wear a mask, stay 6 feet away, cover your mouth and nose, and now get vaccinated. And surprisingly, there's a debate about whether or not people should get vaccines. And so I'd like to address maybe that from a medical standpoint. This is a model that was put out by a virologist who talks about how we can lessen the numbers of infections. It's called the Swiss cheese model. And every layer is imperfect. It's got holes in it. The virus is going to get through that. So it's not that every layer is perfect, but if you stack those layers, the amount of virus that gets to the other side drops to very low, if any, right? So what are we looking at? Physical distance, masks, hand hygiene, avoid touching your face. I think we've thrown that out, so you can pull that slice out. Time of exposure. So if crowded, limit your time. So if you're in an area indoors where there's a bunch of people, if you can limit it to less than 10 to 15 minutes, that lessens your exposure dramatically, even if you're masked. Tracing and testing that's rapid and timely. That's a huge one. We haven't figured that out yet in the U.S. We're better than we were 8 months ago, but still pretty hard. Outdoors, ventilation, air filtration. There's machines now that will filter the air, and most big hospitals, in fact all hospitals have that filtration, but most big buildings are starting to purchase those. I know that with the Spurs at their practice facility, there's a unit in every one of their big common areas, and there's units throughout the AT&T Center. So there's a way to try to help reduce virus just there. Quarantine, isolation, and vaccines is the last one. So let's look at this model. This was a proposal put out by some mathematicians that took the Swiss cheese model and said, okay, how do we get back to normal? How do we open up the economy? Because that's really what we need. We need to get back to life. Can we do it with masks, without masks, with vaccine? What does it look like? So this is their proposal. They said, number one, if you assume that 20% of the people, and that's consistent with some of the studies, that 20% of the people in the U.S. have been exposed, have had it, have some immunity to the virus. That's baseline. If people wear masks and practice distancing, and you fully reopen businesses and whatever, that first column there, the R little zero, it's called R naught, means how many people would one person infect. So that means 1.5, if you assume 1.5 people are infected for every person that you, if you're the one that's carrying the virus, you would infect 1.5 people, and nobody's vaccinated yet, then if we test twice a week, we can open up the economy. I mean, that's everyone testing, asymptomatic, symptomatic, everybody. Okay, well, we could do that. I don't know that we could test though. I mean, that's very logistically it's impossible. How's that? So 2 through 4 are the levels of increasing numbers of vaccinations in the country, and people don't have to wear masks or social distance. What does that look like? Well, the number of people that might get infected with each contact goes up, doubles, it goes to 3, right? So now we're talking about, looks like there's a lot more people that might get it before we get through this. But at levels of vaccination, 40%, 55%, and 60%, you can see the testing that's required. If we can get people in this country vaccinated up to 60%, and we add the 20% that are already relatively immune, that's herd immunity right there. That's 80%. And that virus can't replicate if it doesn't have a host that can handle it. So then we go down to no testing at that point. That would be nice. And then finally, 5 is, look, what if we just get 30% of people vaccinated, but we keep using the masks and social distancing for a while? We still don't have to test. And the R value drops, the R naught value drops back to 1.5. And so that's kind of where we are. We're really in number 1, but if we keep vaccinating, we get to number 5 really pretty decently over the next few months. I think we can get back to normal, but we're gonna have to wear masks for a little bit longer. But wouldn't it be nice to be able to go out and do stuff as long as we've implemented these other things? So let's talk about vaccination real quick. There's two of them in the US, Pfizer BioNTech and the Moderna vaccines, and they're pretty similar. They each got a little twist on how they cause your body to create antibodies into what things on the viral cell. But bottom line is they're darn effective. I mean, if you think the flu vaccine at its best is about 65% effective, 70%. These are 94, 95%. That's unheard of. And that's fantastic, all right? The Pfizer is a 2-shot series, 3 weeks apart. Moderna is 4 weeks apart, also a 2-shot series. But the problem has been, it almost was like we weren't prepared for a vaccine, even though we kept talking about it for months. It's coming, it's coming, it's coming. We're about ready to do it. We're going to approve it. It's almost like nobody was ready for it, like the logistics. So we're struggling with that. We're struggling to get it out. And it needs to be better, and hopefully it's going to be better as people really get after it in the next few weeks. But I have a lot of confidence in it. So let's answer a few questions. Number one, how do they work? Well, the vaccine is what they call mRNA, or messenger RNA vaccine, and basically it causes your body to produce an antibody to a protein that's been given to you through the vaccine that is very similar to the protein on the virus, the spike protein. And so what happens is you develop all these antibodies so that if the virus enters your body with that spike protein, antibodies are sitting right there, and they're like, yeah, no, we're not going to have that. And they attack and destroy it before it can replicate it. So how much will it cost? Well, the government has supplied them, right? So it's really just, the cost really is just the administration cost of the person that injects you, right? So it's anywhere from a few bucks to 20, 30 bucks, I don't know. It's not a lot. Will they work against different variants of the virus? You know, as the virus mutates, and yes, the answer is yes, because it's not just against one thing that this vaccine was developed. It was developed against several different targets, and so those targets are working in tandem, so to speak. And the other way that we develop, therefore, immunity is a different line of cells in our body called T cells, and those T cells also get activated. So now you have a couple of different groups of cells primed and ready to keep infection from going on. If I already had COVID, do I need the vaccine? Good question. We think that the natural immunity to COVID lasts for several months. In fact, good studies show that antibodies persist in somebody's system for 3 or 4 months, but not forever. And that's not crazy, because we see that with other coronaviruses, which is why the common cold can be obtained every year. So you have a little bit of a response, but you're not going to knock it out all the way before it creates an infection. So in coronavirus SARS-CoV-2, if you've had COVID, they recommend not really